Okay, good evening. So I want to talk about what we do, and the main gist of what we're going to talk about tonight is basically keeping people out of hospital. And obviously it's really, really important for GPs to know the information about what we provide so we can work together with this group of people. So I am going to start by saying that it's all about the patient, and although we are winners, and I'll go through all this, it's really the patient who is the real winner if we can keep them out of hospital. Now, okay, so the aim of the game of keeping people out of hospital is that it is best for the patient. They get this, for the patients that we work with out of hospital, they get the same treatment, but they don't get the adverse events, which are very well known, and we see them all the time, and they're very, very sad to see when people fall in hospital. They get severe delirium, they get new infections which they didn't come in with, and they have medication blunders because we don't know what medications they were taking, or someone's given them the wrong medication, or someone's written up the wrong medication. It's definitely best for the families and carers that they can be looked after in their own home, and that includes aged care facilities. It's best for you guys that you can continue to have the ongoing care with our support, and it's best for the hospital because it doesn't mean that we close beds behind them, but basically we can get more people into the beds because these people are not taking the beds that previously they were taking. And the administrators love us for it because we can minimise the number of people coming through ED, although the numbers going through ED are still massive, and Sutherland Hospital has just overtaken British Wales Hospital, doing 54,000 admissions through ED in a year. Now, why is it better for the patient, apart from being home, which is really important, but this particular article has been basically the article that we've all based our decision making on, and that is, this article says that basically the people who went home versus the people who were in hospital for the same conditions had much less delirium, and that's why it's better to be at home rather than in hospital. Now, the Southcare, which is the aged and extended care at Sutherland Hospital, and doesn't overtake everything that the Sutherland Hospital community provides, and we will be hearing from other speakers from our hospital. But it's the big department. We provide people care in the community, in the hospital, and in aged care facilities. And I won't go through everything we do, but we do a lot of things. So basically, for the hospital, which previously was the mecca of medicine, for particularly the older people sitting here, is no longer the mecca of medicine. Basically, the community is, and we provide a lot of services in the community. So we do still provide a lot of services in the hospital, acute care, orthogeriatrics, rehabilitation, palliative care, but we also provide a lot of services to the community, and we also provide a lot of services to the aged care facilities. So Southcare is a one-stop shop for aged care and extended care. The provision of quality services and care for older adults and people with a disability who are residents of the Sutherland Shire to enhance independence, quality of life, and to optimise health and well-being. And we've been going for 30 years, and this year we're celebrating our 30th birthday. Now, I don't have to tell this audience what's happening with ageing, and the really increase in age means increase in chronic diseases and an increase in need for services. So I quickly want to review 4 models that we put together to try and keep people out of hospital. From an aged care point of view, geriatric flying squad and our Sutherland outreach service. From a general medicine point of view, radius and hospital in the home. So the geriatric flying squad, I won't go through this, but basically this is a team that provides care to deteriorating residents of aged care facilities. Now, we know that 11% of the Australian population are over 70, and in this particular Shire, it's 13%, 8.6% of the over 70s live in aged care facilities, 30% over 85 live in aged care facilities. They're frail, they've got complex medical problems, if they come into hospital, which they've got a 25% chance every year of coming into hospital, they will stay 7 to 9 days, and they get false delirium and infections, as I've mentioned. And if they go back to the aged care facility and they don't die in hospital, there's a 40% chance they're going to die within a year and an 80% chance they're going to die in 2 years if they have had that hospital admission. So this is particularly why we're dealing with a very chronic palliative care group. And that's particularly why we don't want to admit them to hospital, but keep them in their own homes. So the geriatric flying squad includes a geriatrician, and at the moment we've also got a GP registrar, nurse practitioners, and clinical nurse consultants. And the idea is that to improve the quality of aged care service by provision of a timely and effective service going down into the aged care facilities, reduce emergency admissions, reduce transport to emergency department by ambulance, reduce the adverse outcomes I've mentioned, to improve the palliative care services, and to reduce the impact of unnecessary transfers, as I said. So this is a review in 2014. Yes, it's 10 years ago, but nothing's changed. We've actually continued this. It's exactly the same. That we did a survey, and for patients, families, and general practitioners were all 100% keen on the idea of this team going down. And half the patients were managed, were able to be followed up, and we followed up GPs and we followed up families, and 100% said they really liked the service. And in that year, we had in the 3 years, the first 3 years of the geriatric flying, so we had 1,000 referrals. And we intervened on a little bit less than 1,087, 1,037, and only 97 were hospitalised. We were able to manage 980, 90% in the facilities without being transported to hospital or ED. And if they were hospitalised, half of them could go to a ward bed straight without going through ED. The other half had to go through ED because there were no ward beds. But 90% were able to be managed. Previously, before 2011, all of these patients were brought into ED by ambulance. And so we followed this up later in 2018, and we were able to have this publication, Southcare Geriatric Flying Squad, an innovative Australian model providing acute care and residential aged care facilities. And it basically showed very similar that we were able to keep, in this case, 93% of people in the aged care facility and not admit them. And their average length of stay on our service was 2 days, basically. And I mentioned previously, if they were admitted, they were going to stay 7 to 9 days in hospital. The mean age of patients were 86. The male to female ratio was 1 to 2, which was what you'd expect in an aged care facility. We treated delirium, chest infections, and aspiration pneumonia. 25% of the patients we saw, we didn't treat acutely. We put on a palliative care life plan. We treated cellulitis and pain management. They were our common reasons. And the average time to get to the aged care facility after the referral was received was 91 minutes, which I think is absolutely exceptional. We did a lot of things. We do subcutaneous fluids, we do IV fluids, we give IV antibiotics, we put catheters in, but 25%, as I said, ended up on a palliative care pathway instead of having any of that acute care. Or did we actually save money? No, because all our beds at Sutherland Hospital were taken up by other people, so we didn't close beds behind them. However, we stopped all those patients coming in so other people could get those beds. And what we worked out is that the efficiency was $4 million. We were able to keep those patients out, and that would have cost $4 million if they come in, and our team cost $400,000. So it was basically a benefit of $3,600,000. And how was it successful? We had a great team in 2011 that we put together, and we've got an amazing team in 2024. We have relationships with key stakeholders, which are basically aged care facilities and GPs. Good communication. We are very organised and integrated. and we're integrated with our Southcare team, which is 180 people, and we have equipment and consumables. So there are relationships. What do we take along with us? A mobile phone. We have a motor vehicle. We don't yet have a helicopter, but it'd be nice to get it. And that's not really our vehicle. We have point of care technology that we can actually check electrolytes, full blood count at the patient. And we have ECG, we have bladder scanners, syringe drivers, it's all in the booth. And these are all used. And we have lots of medications that we can use as well. And we might call for portable x-rays, as in, has the patient got pneumonia, has the patient got a fracture, and we might get the blood pathology, but we already have the pathology, the basic pathology. Let me go on to Southcare Outreach Service. I won't spend too much time on this, but to say that the Southcare Outreach Service is exactly the same as it's another team, but it's exactly the same as the Geriatric Compliance Squad. It's just the Geriatric Compliance Squad goes into aged care facilities and the Southcare Outreach Service goes into people's homes. Now, the big difference is in Geriatric Compliance Squads, they're going to aged care facilities where there are nurses to continue on intravenous fluids, subcutaneous fluids, intravenous antibiotics, whereas at home it's much harder to do that. So our treatment is different. And the other thing we have is that we have, if we look down the bottom, it's a multidisciplinary team. Because in aged care facilities, we've got nurses, we've got occupational physiotherapists, we don't have to have that in our team, we just have doctors and nurses. Whereas this team goes into the people's home and we have a full team of nurses, physiotherapists, occupational therapists, we're social workers, geriatricians, and we work very closely with our general physicians who work in radius, which I'll come to. So lots of referral sources, GPs, ED, so they can be going to ED and be sent home and be followed up by this service. But this is our biggest one, New South Wales Ambulance. So New South Wales Ambulance get called to the home, someone's fallen over, someone's got delirium, something like that. They ring the SOS and the SOS goes down and assesses them and the ambulance goes away. Occasionally they might transfer the patient to radius for further investigation. Interventions are not quite the medical interventions that we have, but lots of other interventions, doing an assessment, getting people off the floor, working out why they're falling, doing medication assessments, doing pathology, and believe it or not, they can get an urgent ACAT and actually put the person in respite within 24 hours, which again is fairly amazing. And their data shows that of all the people they've been referred, 99% was still at home without a hospital admission, which again was quite amazing. The squad, which included confusion, cognition, so delirium, falls, infections, those sorts of things. Now, we did set up a couple of years ago, moving away a bit from aged care into general medicine, the radius, which basically is the rapid assessment diagnosis intervention unit at Sutherland Hospital. It opened in 2018, Monday to Friday, 9:30 to 6 o'clock. Referrals received from GPs, and we're hoping that after tonight we get more direct referrals from GPs. Many of the referrals came from ED. Someone was triaged in ED as suitable for radius. Ambulance again was involved. We have a very good relationship with ambulance, and they brought them straight into radius. And SOS was also involved in sending people into radius. Now, it's an alternative pathway to ED. And basically, it's a patient who's deteriorating, but not severely deteriorating. If they're severely deteriorating, if they're in the Geriatric Compliance Squad, if they're in the nursing home, the Geriatric Compliance Squad will go there. If they're at home, possibly the SOS will go there. If they need further investigations or they're quite sick, but they're not the sick of going to ED, requiring lots of care and obviously needing admission, then they should come to radius. And as I say, they are pulled from emergency department as they're being triaged. And what we've got in Radius is direct service of general physicians who actually see the patient directly, immediately. So basically the person comes in, they're seen by nurses who are very highly skilled. They're also then seen by the general physician. All the tests are organised. We have very good relations with pathology and radiology so that we can get results quickly. And then most of the patients are then sent home within 4 hours. So they've had their tests, and then they can be followed up by either SOS, by Radius, or just in consultation with general practitioners. We have a whole lot of Radius criteria. I haven't got time to go through it all, but just they're not sick enough to require admission, but they're pretty sick and they need some type of urgent assessment. So there's a lot of the conditions we see: dizziness, urinary tract infections, anemia, back pains are very common, cellulitis very common, maybe a new diagnosis of hypoglycemia that needs a few investigations done quickly, hyponatremia, leg edema. Time in a Radius, just less than 4 hours. Most of these patients would be spending at least 8 hours in ED. Now, just a very busy slide, but this is the average time in Radius. So basically in hours, so I said somewhere between 0 and 4 hours is the average. If they're admitted to a hospital, they would be basically staying in about 2 to 5 days. So that's what we have been able to reduce. Now, this is a study that one or two of you have probably were part of. You were sent 5 cases that had turned up in ED, and you had to read them and tell us, what would you like to do with this patient? Would you like to treat them yourself if they would have come to you straight rather than going to ED? Or would you like to send them to Radius instead of sending them to ED? Or was it right that they went to ED? And it was found that of these 50 patients, and 10 GPs were chosen to look at 5 cases each, 42% would have preferred them straight to go to ED, which they did, and 58% of those patients could have been looked after in Radius, and at least 14% of those 58% could have been looked after in the community, mainly by GPs, but 14% could have been managed by going to Radius and then going home rather than going to ED. And that was a publication that we had, which was very nicely done by one of our registrars. And the last one I'd just like to talk about is hospital in home, which is the new team on the block. Basically, and most of you know a little bit about hospital in the home, basically patients who either are seen in ED or can be seen in the community who get put on hospital in the home where they need things like intravenous antibiotics, or they need to be looked after by skilled nurses and doctors who can go down and look after them for a couple of days, basically by reviewing them and seeing whether they're doing okay, whether they need to come back into hospital, or whether they need some ongoing treatment such as intravenous antibiotics. This is our staffing. We have 6 FTEs, including nurses, staff specialists, gen meds, staff specialist, registrar, pharmacist, occupational therapy, social worker, and physiotherapist. Again, very big inclusion criteria, very similar to Radius. Now, I just want to show you the red ones because they're not very general medical. In fact, a couple of them are very surgical, a couple of them are very obstetrical, and our general physicians have become very good at obstetrics, not actually providing the actual delivery of the baby, but the medical side of obstetrics. And Claire particularly is going to talk a little bit, is very good on this. But what we're doing is the hyperemesis gravidarum takes up a lot of hours in ED because people come in vomiting, they sit on IV drips, they go home, they come back, next day the same. So we're trying to put models of care in around that. And this is a good way to do it through a hospital in the home. Mastitis, post-cesarean wound infection. So I've just shown that these people who we're looking after are not just general medical people, they're often surgical patients, and we look after them as from a general medical point of view, but we also have the skills of the surgeons whose patients they are, who can be involved as well. Lots of exclusion criteria as well, I won't go through that. And I just want to bring your attention of how things have been increased over 2023-24. We started off with 11 patients per month, and we're now up to 191 patients in a month. And the readmission rate is only 4%. The readmission rate of our patients, generally, if we look at all our patients who've come into hospital for aged care, is 25% within 28 days. So, in summary, we have 4 relatively new models of care, trying to keep people out of hospital so they can be looked after in the community. If they're in an aged care facility, they should be treated by the geriatric flying squad. If they're a community patient, they should be treated by the Southcare outreach service. If they're a community patient needing acute investigations and they're not too sick, they should go to Radius. And if they're a hospital patient who can get out within 1 or 2 days instead of 5 to 8 days, then they should be treated by a hospital in the home. But that can be extended to community patients as well. So in conclusion, if possible, let's treat the patient in a community. It is safer, it is more efficient. Everyone asks, do we need more research on this? We have so much data that we've given to the Ministry of Health and everyone else. I'm glad to say that, for example, the geriatric flying squad started here in Sutherland Shire, and we now have 4 across our district, 1 at St George, 1 at Walmora, and 1 at Prince of Wales, and we all work very closely together. And now there are geriatric flying squads in Bankstown, in Liverpool, and in other places, and North Shore's got a lot, got a really good service. So it's gone across New South Wales, it's gone across Australia, and I was able to go to the UK and talk to them about the geriatric flying squad, and they're taking it on too. So it started in the Shire and it's just exploded, and it is now absolutely core business. So do we need more research? No, we've got plenty of data. We've told everyone our data. What we do need is we need more of it. We need more staffing. We need more communication with GPs, more referrals. We need more communication with other specialties. I think that every specialty should have a radius so that people, you know, if you've got well, actually at Sutherland, they do have a bit of a pediatric radius called Car Clinic, which is really, really good. But every subspecialty should have a radius where people can go to without going through ED and go home again and be followed up. It's, as I said, it's going throughout other districts, but it needs to go through more districts. We need to have some type of relationship with remote and rural, perhaps doing it by video conferencing, going across Australia, and as I've said, going to the UK. And I'll stop there. So I think now we're going to have a couple of case studies. Is that right? Yeah. Good starting. The video is going to play.
Hi everyone, I'm Seema Chikawabuda. I'm one of the geriatricians and the physician. I work in Radius. I'm going to present the first case, and Dr. King will present the next one. I'm presenting the 83-year-old lady that I saw in Radius. She was sent into ED by her GP with left leg cellulitis. She was on oral antibiotics for 2 days with minimal improvement. She hit her leg on a wooden furniture and had been swollen since then. Her background medical history includes rheumatoid arthritis and hypertension. On examination, initially in triage, she was not tachycardic. When we brought her to radius, she was quite tachycardic. Her heart rate was 120, was irregular. Her blood pressure was 135 over 75. She was saturating reasonably well, 96% on the neck. She had a swollen left leg with mild cellulitis. We did ECG and radius, which confirmed new atrial fibrillation. In terms of the social history, she's quite independent. She's from home, no underlying cognitive issues. She's an ex-smoker, which is significant. I'll come to this later on. So I decided to do a Doppler, which showed below knee DVT. You must be wondering why I chose to do a CTPA, because she had no air and she was quite tachycardic. I thought she might have a PE as well. But we picked up speculated lung mass, which is likely primary lung cancer. You can see that on the scan there. So her current issues now are new atrial fibrillation, a below knee DVT, and a new lung lesion, perimalignancy. So subsequently, I got few teams to see her. The reason I got cardiology to see her, I was seeing her at 3 o'clock in radius. She was still quite tachycardic. I was wondering if she needs admission, I'll let them know. And I also considered an echocardiogram down the lane if required. She was also seen by my respiratory colleagues to organize outpatient follow-up for the lung lesion and further investigations. I discussed with the on-call radiologist and booked her in for a CT guided biopsy. The next question was anticoagulation. This lady has a new AF, a new below knee DVT, and I'm planning to do a biopsy. Should I anticoagulate or not? I'll come to that later on. The cardiology registrar was very kind. He came and did a bedside echocardiogram, which showed mild MR, mild TR, and mild systolic dysfunction. She was commenced on metoprolol 25 milligrams, and she responded quite nicely to that, and her heart rate improved. She also got loading dose of apixaban. We decided to start apixaban because we were not able to get biopsy within a week. So we decided to load her with apixaban for a week, and then reduce it to 5 milligrams. She was also reviewed by the respiratory consultant in radius. A CT guided biopsy was booked after 3 weeks. I also organized a PET scan for her within 4 weeks after liaising with nuclear medicine at St. George Hospital. So this lady was very anxious. She was quite worried about being on blood thinners. She called me a few times on my radius days to find out if she should be taking apixaban. We reassured her she continued apixaban. I gave her advice about stopping it 48 hours prior to biopsy, and again did a phone follow-up and recommended recommencing 24 hours after she had the biopsy 3 weeks later. In terms of her results, she had a PET scan which showed 2 FDGF lesions. One was 27 millimeters that we could see on the CT scan, and another small 10 millimeter lesion in the right upper lip. She was reviewed by oncology in the clinic, and stereotactic ablative radiotherapy was recommended. She successfully underwent radiotherapy. She remains at home. She's had one further presentation to ED in the last 12 months for COVID and has been discharged home. So all this was done in outpatient setting, community facing, without requiring hospital admission. The outcome was pretty good. The timeline. She was triaged at 1 p.m. I saw her in radius at 2 o'clock. Sorry, that should be 23. I saw her at 2 o'clock. CTPA was done at 3 o'clock. She was reviewed by 2 inpatient teams quite promptly. She had a CT guided biopsy week 3. She had a PET scan week 4. She had respiratory follow-up week 4 and oncology follow-up week 6. By week 8, she had completed therapy. I'll pass it on to Claire. Thank you.
So my case is that the 49-year-old man who we actually got from triage in the emergency department. He had a 3-day history of fever, productive cough, shortness of breath, vomiting, headaches, and quite significant rib pain on coughing. And the thing that was worrying him the most is when he was lying down, he could hear him crackling. When he was breathing, he was quite concerned about that. He's got no medical problems, no regular medications. He's a non-smoker, no respiratory disease. He saw the GP a day or two earlier, who appropriately did an extended respiratory PCR, which was negative. So when I saw him, he got quite unwell actually. He was febrile, tachycardic, but reassuringly, he had good blood pressure and he was maintaining good saturations. He'd had quite a bit of vomiting and he was clinically dry. He'd spent the last few days in bed. His heart sounds were dull, chest was clear, abdomen was soft and non-tender. Investigations showed his platelets were a little bit low, but he had CRP of 110. We took some blood cultures because of the fever, and we sent influenza swabs. And I was still thinking this chap has some kind of virus, but he looks quite miserable. Anyway, I got an X-ray. Doesn't predicted that well, but you can see he's got interstitial opacities in the right bone. So this man has community-acquired pneumonia. So in radius, he received some IV Traxone, oral doxycycline, IV fluid, and on Nurofen. But I got kind of a bit concerned with him because he'd been having headaches, but he was very uncomfortable with the headache, and he said it had progressed throughout the morning. I re-examined him. He had no rash, no meningocele. And one thing that we do have in radius is we do have the benefit of observing someone. We only were open 9:30 to 6, but he stayed in for 4 or 5 hours because time is a very good diagnostic tool. So he had a bit more IV fluid. We had to give him some endo because it was actually quite severe. But towards the end of the day, his temperature settled, his tachycardia settled. He still had a bit of a headache, but it was much better than when it was at its peak. And we put him to hospital in the home. So we have quite a good relationship with hospital in the home. We are co-located within the same areas. We're very close colleagues. So it's a very easy referral process for us. So he actually had a further 2 doses of IV Traxone with hospital in the home and continued doxycycline. He improved and then was continued on oral antibiotics, and the plan was made for the GP to arrange a testing at 6 weeks. For this man, I actually also sent off a atypical bacterial PCR because I don't know if you've already, there's more mycoplasma around the province, and his PCR came back positive for pneumonia. So we often see that more commonly in children, but he had it, and I've actually had a few cracks with this in my use recently. So if anything, the doxycycline is probably what he needed, but he had the Traxone, and it just gave me that reassurance when I was sending him home. It was actually quite a 50-50 decision. He's looking quite sick, whether to admit him or send him home, and it just gives us confidence that we know there's that's the team that is going to look after him. And then we'll just got a photo of us. This is the general medicine radius hospital home team. We do have a mobile that we carry in radius. One of the physicians, you can contact us directly, or that is the number for the admin that they can get to us as well. So please call us. We're wanting more referrals from GPs. Even if you're just, not sure what to do with the patient, and, run it, call us up, and we're happy to give it advice. Right, does anyone have any questions?
What's the count normal in this patient?
The
White cell count?
Yeah, normal white cell count, actually, I think.
Should we be thinking about starting doxycycline with a loss with our COPD patients at the moment?
Yes.
Because of the current epidemic.
Yeah.
So not waiting to see that they're not getting better, but starting.
I think so. Yeah, just for a while. I mean, so I've got it from the moment.
Yeah.
I will.
So on examination is just supposed to be.
So these are the cases of suitable patients with AS.
Yeah.
What about like just the general finding of rapid AF? Which I guess I say rapidly because I think if it's rate control, it's happy to manage that in the community.
Yes, of course.
So when it's rapid, a little bit of distress to EG or to radius.
Yeah, so I think seeing this case, that she presented, you know, the patient initially came to radius with cellulitis and we picked up that she had AF. But I think in that situation, I mean, we still, you know, have got to be sure our inclusion criteria, so we're generally looking, so that would be so that's a really issue with cardiology, and we don't have to limit beds in radius.
But if you watch this space, you know, and they will be, the cardiologists are working on a wall where you can send your AFs to them straight, and then they can just basically echo them, slow them down and send them home.
Yeah, what I told you today.
So but at the moment, they're going to be there, and they're seeing them there and sorting them out very quickly and getting them out. Unfortunately, as you probably know, if you go to ED, there's a really good chance you might be there for about 4 hours before you even see them. So that increases the amount of time. But once they've seen them, a lot of them are going home now.
But there's a just thing, of the discharge, cardiology.
Yeah, that's right. So that's why I said every solution over others.
I recommend.
Question about the hospital in the fall. Can we as GPs with her directly, or it has to go through either radius?
Well, it has to go through radius, but
It is already, yeah.
at the moment. Is that correct?
Yeah, at the moment that is the case, but I think that if you rang them and if they're available to sort of see the patient very quickly and talk about, and that's a possibility. But at the moment, it was through ED at the moment. Or patients who've already been admitted to a VAR two and then they get discharged earlier than they would before. We've only just started, I mean, I don't know, it's about maybe 6 months at the most. Hospital and home, but we will progress and I think that's a really good point that we need to do that. But at the moment, we're very keen for you guys to refer straight to radius, where they can then link into hospital and home or Southcare at mid-service.
Please call us. We get so excited when the GPs call us.
So that's it,
You called last week.
bring that mobile number, that's the
Yeah.
first thing, bring that mobile number.
Yeah.
Explain the case. And it's
Yeah, but
definitely-
I'll write this one down, just in case, because obviously we can be with patients busy and going work on wards sometimes as well. So, you know, the second one, well, you'll always get some. Yeah,
And it's between 9 and
9:30 and 6.
9:36, Monday to Friday.
Yeah, but even if you call us and, you know, even if it's later in the day, because obviously we need time to, you know, do our investigations, and we could say, you know, do a bit of a risk assessment and say, okay, well, how about they come in at 9:30 tomorrow morning?
Yeah.
Yeah, work on that. All right, thanks everyone, looking forward to your call.
Next up, we've got Andrew Lawson, who is from the patients department. So
Hi, my name is Andrew Lawson. I'm actually the physiotherapy clinical partner at Sutherland Hospital. But what I wanted to tell you about was the Sutherland Hospital Allied Health Outpatient Services. So this is our effort to keep people out of hospital, or otherwise it's the way that we support this from hospital as well. And these are publicly accessible services. They might be particularly relevant to your patients who have limited access to private allied health services in the community. And we paused during COVID, or we went virtual during COVID actually, but we've been back to business as usual for the last 18 months or so. And so this is our opportunity to just remind you that these services are available for you to refer to. So let me start with the thing that I know about best, which is physiotherapy. So at Sutherland, we have a strong presence within ED and radius. We have a physiotherapist there every day, 7 days a week, from 9:30 to 6. And they're performing a primary and secondary care physiotherapy role in ED. And they make good use of referral pathways to our outpatient musculoskeletal service as well, which I'll tell you about in a moment. And excitedly, we're just about to embark on the reshaped clinical trial, which is comparing primary care physiotherapy with usual care in emergency. So some of the hospital-based outpatient physiotherapy services, first of all, we've got a musculoskeletal service, and that operates from Monday to Friday. And that is a secondary care physio service, so you get a referral to see patients in that service. We also run OSSFP, and that stands for the Osteoarthritis Chronic Care Program. So we're caring for patients who are on elective joint replacement wait lists. And a small proportion of those patients end up, progressing with the program and coming off the elective joint replacement wait lists. We also have a paediatric physiotherapy service, and that's with primary and community health. And we run a limited rehab outpatient service as well. And so how to refer to physiotherapy at the hospital. So that's through the allied health, the hospital allied health intake, either by fax or by. The next one is occupational therapy. So they have outpatient services for upper limb and cognitive rehab for the patient post-stroke. And again, you can refer through the hospital intake. We also run, and this is between occupational therapy and physiotherapy, there's constraint-induced movement therapy, which is a 2-week intensive program for people following stroke or brain injury. And in 2024, we're going to run that program 6 times across Southeast Sydney. 2 of those will be at Sutherland, and that will be in April and November. And to refer to CAMT, you do that through the district CAMT website. There's a hyperlink there if you get the presentation. And Peter also earlier referred to occupational therapy being available through Southcare. And to refer to occupational therapy in Southcare for patients over 65, that would be my aged care referral. Or for patients under 65 and not under NDIS, that would be through the Southcare intake. And that would exclude NDIS clients and DBA card holders and permanent nursing residents. Speech pathology, outpatient speech pathology is available. So they run a service for dysphagia assessment, and they do MBS or BFSS. And the referrals would be via the allied health intake by fax. And I ask that if you're making referrals for MBS, that you please provide radiology request form or a letter with specific details regarding the reason for the request, and specific request for yes. There's outpatient social work services, so they identify patients through antenatal, for example, and then follow those patients throughout the pregnancy. And similarly with through the oncology clinic as well. They're also quite active in emergency and are an important part of Radius. And intervene particularly with domestic and family violence. They have a 24/7 on-call service in that way. They intervene with child protection concerns and sexual assault. And just noting that for forensic investigations, patients need to go to St George. That's not available at Sutherland. Podiatry. At podiatry, there's available for referral the high risk foot service. So they care for patients with acute wounds or chronic non-healing wounds or sharp foot. And you can refer direct. They've got a clinic number, or I've got a bunch of referral forms if you want to take some of those as well. They have a CHSP service, and that's prioritised for patients with loss of protective sensation, or who have had a previous ulcer or imputation or peripheral vascular disease. But the referral for CSHP is through my care. And then there's a multidisciplinary clinic which is run at St George, and that's run fortnightly. And that involves vascular orphan rehab, and there's a podiatrist and an orthotist involved in that clinic as well. And you can refer via that that phone number or through the forms that I have here. And last but not least is nutrition and dietetics. So they provide a nutrition support clinic. They must be ambulant patients discharged from the hospital and at risk of nutritional decline. They also run a paediatric clinic, and they accept referrals for patients who are examples would be failure to thrive or enteral feeding, fussy eating, or food allergies, or other conditions by exception. And they're quite closely linked with the renal clinic. But for all of those clinics, they must be Sutherland Shire residents. And for housebound elderly, the referrals would get passed straight on to Southcare. And the more complex gastro conditions would be passed on to St George, that have a broader clinic. And diabetes will be referred to the diabetes clinic, and NDIS are referred privately. So that is the allied health outpatient services. Does anyone have any questions about those? We thought we would take the opportunity to these are probably clinics that you're referring to, maybe clinics that you're referring to on a regular basis, but this is just a reminder coming out of COVID that the back to business as usual and accepting your referral capital.
Are you running stepping one again?
Yes, stepping on has been going on.
Shut the part one meeting.
Yep.
Yeah.
Yep, absolutely.
Just a quick, all these clinics are not, anyone can go to these clinics, you don't have to be a low income person or that sort of thing, so it's available to everyone.
It's available to everyone.
Yeah.
I just make that point just in case you, there'd be some of your patients who have limited access to private health services, and we've got to get it. It's a, particular option for patients.
Average waiting time.
Waiting time. Yeah, good question. Look, that's different for all the services. I can tell you about physiotherapy. For our musculoskeletal service, it might be, generally speaking, for acute conditions. So post-op conditions will be seen within 1 or 2 weeks. And for chronic conditions, it might be more like 4 to 6 weeks, 6 weeks at a stretch. But we're just about to cut that down. We have ebbs and flows with that, particularly with our students coming through. And so, yeah, we try to be very responsive to the musculoskeletal ones. OSSP might be somewhere around about 8 weeks or so. And the other disciplines I couldn't do that, sorry.
Thanks, Andrew.
Thank you.
Next we've got one for Ian Gleason, update us on health pathways and how to develop.
Yes. And I'm going to ask you to get out your phones, because I thought I've talked about health pathways so many times over the last few years. You see my face on webinars, and but what would be really good is for those of you who haven't used health pathways before to use it tonight while we're going through this very simple case. I should have collaborated with the previous two speakers, because my case is similar to one of them. Just a point that Sydney also has a health pathways site, and whereas their referral information is going to be relevant to the Sydney local health district, sometimes they have pathways localised that we don't have. And if your patient lives in the Sydney local health district, then it's helpful to use their pathways, because you can find their local resources as well. So a case presentation. Mrs. G, age 76, comes into your surgery, attending by herself, having driven in, and she's well known to you. She has pain and redness in her red lower leg, present for 2 days and getting worse. And she's feeling a little unwell. And you have a look at her leg, and that's what it looks like. On examination, the temperature is 37.5, blood pressure is 130 on 85, pulse is 85 and regular. She has no lymphadenopathy, and she weighs 75 kilograms. Please make this interactive. What are you going to do? Are you? Not yet. It's like, have you identified anything that makes you think you need to send it a radius yet? Like, are you going to give her antibiotics, or are you going to send her to the hospital? Antibiotics. You're going to start some antibiotics, like I would, right? But what I want you to do now is open up the health pathway on cellulitis. So I've given you a QR code that you can scan with your phone, and it'll open up the cellulitis page.
What's the
Oh, didn't I give it to you already?
Yeah,
You did, that was 500 times. SC Sydney and Healthcare. That means you've never used health pathways on the phone. Tell me when you've got it open. Everyone got their password going? This means every time you open your phone with health pathways now, it's going to be there. Bookmark this. All right. So we're going to open up health pathways, and when you look at the cellulitis pathway on your phone, you'll see some red flags. You'll see some background if you want to read it, and then it takes you through assessment, looking for typical characteristics of cellulitis, looking for complications, identifying any high risk factors or comorbidities, considering alternative diagnoses, because not every red leg is cellulitis, and then think about any investigations you might want to do. And in your assessment of the patient, this is a bit more further history that you get. She lives alone and she's independent. She has type 2 diabetes, and her last HbA1c was 6.7. She has venous insufficiency. Her last eGFR was 46. And she's on Crestor, Ramiprazole and metformin, no allergies. Does this change your management on her first presentation? So, anyone got anything to say? Like, I will admit, I would have gone, well, most of my old patients are like this, and I probably still would have given them oral antibiotics. But if I look at the health pathway, what it says, if you go down to the management number 3, it says, arrange intravenous antibiotics by requesting emergency assessment, which is send them to ED. or via hospital in the home, because some areas have hospital in the home where GPs can refer, or rapid assessment, diagnosis and intervention service, our friends at Radius, or GFS, if the patient has significant comorbidities. And some of the comorbidities listed in that are venous insufficiency, edema, obesity, lymphatic obstruction, previous history of cellulitis, diabetes, alcohol dependency, vascular disease, elderly, and immunocompromised. So the health pathway, if you checked it, I mean, and most of us are feeling confident with cellulitis is GP bread and butter, but this is a reason to look at health pathways a little more often, right? It indicates that this patient would actually be suitable for Radius. And what would happen is you would ring the mobile number and speak to them and say, you know, they've got renal impairment and diabetes, they're at risk of AKI, they've got comorbidities. I think maybe we should start IV antibiotics, and Radius can assess them and organise hospital in the home for IV, give them their first dose, organise hospital in the home for them to get another couple of doses if your practice doesn't give IV antibiotics. My practice does. We probably would bring them in once a day for the next 3 days and give them IV antibiotics, but not every practice has that capacity, right? So then you've got this thing that keeps them getting the treatment they need in the community that's a bit higher level than what we normally do in general practice, that keeps them out of the emergency department. So the outcome, having looked at health pathways, the patient has comorbidities that make it more likely they'll need IV antibiotics to send them to Radius. And they may involve the Southcare outreach service as well to see if there's anything else that needs to be done. And they may find complications like an irregular heartbeat and atrial fibrillation in lung cancer. My last patient who was diagnosed with lung cancer at Sutherland Hospital was sent home with this magic plan, but no actual confirmation of an appointment at the oncology clinic and a PET scan. And they came to me and I had them on chemotherapy, biopsied by the time they were called by the hospital. So the communication is sometimes a bit of a letdown. You're still on the cellulitis pathway, so I want you to scroll down. One of the reasons I wanted you to use this is because someone said to me recently that they thought health pathways was only for referrals, right? But it's actually for clinical management as well. There's a lot of conditions that are manageable that are in health pathways. We've got 600 live pathways at the moment now, which is quite a lot, right? If you scroll right down and get to the request part, because we always have assessment, management, and then request. And request is you are requesting another service for your patient. It's not called referral because we're not handing the patient over, not expecting to get them back. We are requesting a service to come in with us to manage the patient as part of their team. Do you understand the difference? Like it's a philosophy we have in health pathways. And if you get down to, the fourth big bullet, arrange intravenous antibiotics. If you click on that link to Radius, it'll actually take you to a pathway that's called acute general medical assessment. And you know how we were shown that great big long list of criteria for Radius? The criteria is listed there, the patients that they will see. And then if you click on contact the service, it's got the numbers that you were shown on the slide. So one of the things I wanted to do today was demonstrate how what you've learned today, you now know where you can get it from your health pathways, okay? I wanted to also tell you about some helpful pages related to tonight. We actually have a page called Sutherland Hospital Outpatient Services. So if you're like, what's there? Like last time I looked, they had one gynecology clinic, now they've got 5, right? So if you're curious to know, or if you've got a patient in front of you and they've got a liver problem, they don't want to see a private liver specialist, you can look and see if there's a liver clinic at Sutherland. I can't remember if there is or isn't, but you can check that sort of thing. If the patient says, I don't have private insurance when I go public, you can check it. It's got a list of every outpatient service that we've mapped so far. And there's one for St George, and there's one for Prince of Wales, there's one for Sydney Children's Hospital. Acute older adults health assessment has got links to the geriatric fire squad and HIP and some of the other services. Acute general medical assessment is the one that's got radius. But even, oh, just do that again, open up that health pathway and go right, see that little magnifying glass, that little search icon. If you type into the little search icon radius, the first link it gives you is an acute general medical assessment. So it will take you, that's a way of searching for it. Okay. There's also a page on general practice colleague referrals. So if you're looking for someone who does medical termination of pregnancy or transgender care or something that is not available in your practice and you'd like to send the patient to another general practitioner who has a special interest, some of the GPs in our area put their hand up to say, yes, we're happy to take referrals from other GPs and act like a consultant. Like the idea is we do the episode of care, and if you've actually written a letter to the GP on that list to say, please look after my patient for this thing, they should write back and say, we've given your patient an iron infusion, you know, or whatever it is. And seeing that I get this chance to advertise some of our new pages. We've got a really, it's actually the first time anyone's done this pathway in the whole health pathways community is rationalising opioids in acute pain. So you get a patient home from hospital on opioids with acute pain, and you don't want to develop into chronic pain, how you can approach that problem. Okay. Transgender health, finally, we've got them up. And there's an update on the certification of death pathway, which deals with the new death certificate that you have to order. It's not available online, and it's compliant with voluntary assisted dying. It's a 2 A4 page thing. Immunisation in adults has been updated recently with Shingrix and with the new RSV vaccine. Ophthalmology referral pathways have you heard of the statewide referral criteria? Has anyone? So New South Wales government has introduced statewide referral criteria for some outpatient services. Ophthalmology and gastroenterology are live at the moment, and there's new conditions coming for both of those. And ENT and orthopedics are going live in May. And so ophthalmology has been updated to take into account statewide referral criteria, and gastroenterology is on its way. And we've updated COVID-19 medications and post-COVID conditions, and there are 2 RACGP webinars coming up on those in the next few weeks, which you might see my face on that square again, but just to keep you in mind that they're still available and worth looking at. So thank you very much.
Good evening, everybody. My name is Sandy. I'm one of the clinical nurse consultants that works with the Planned Care Health team across the area. We are a district-wide service that is an interdisciplinary team. So we have occupational therapists, social work, nurses, pharmacists, and we provide care coordination, navigation and health coaching for patients 16 and over with a background in chronic disease. The aim is to keep patients well in the community and reduce the risk of rehospitalisation and hospitalisation. The program runs for 12 weeks with a key focus of delivering person-centred care, promoting wellness, empowerment and enablement. We do this by working with services to facilitate and deliver care coordination, care navigation and health coaching. We're supported by South Eastern Sydney Local Health District, New South Wales Ministry of Health, the Integrated Care and Population Health.
Everyone is unique, with individual health, psychological and social factors that impact their health and life. The Planned Care for Better Health, or the PCBH program, helps individuals achieve their desired health outcomes by working collaboratively with their GP and other health professionals to support their own individual needs. The PCBH clinical team connects the patient, family and carers with health professionals and programs to assist in making the best decisions regarding their healthcare and experience. PCBH allows healthcare workers to focus on treating the patient as a whole, rather than just any one diagnosed chronic condition. PCBH can be offered to anyone who feels that they are at risk of hospitalisation in the next 12 months. The program utilises a new system which identifies people at risk of hospitalisation by considering complex conditions such as age, gender, rurality, Indigenous or ethnic status, and other health, psychological and social factors. Once an individual is identified, a clinician will use health assessment tools to guide their decisions about what care and interventions best suit the individual's needs. The clinician will discuss with the patient if they have a registered GP and encourage the patient to make an appointment as soon as possible. Evidence suggests that those who attend a GP within 2 weeks of discharge from hospital are more likely to avoid readmission in the next 12 months. Following enrolment, participants receive at least one of the following 4 interventions: care coordination, health coaching, or care navigation. Care coordination is the central role of the planned care for better health team and includes the identifying and linking of PCBH patients with relevant services and interventions. These include health, community, and social services to help balance the other aspects of their life too. Care coordinators will regularly communicate with GPs, providing enrolment and progress reports, shared care plans, and a continual discussion on the individual's needs and best interests. Health coaching is working in partnership with consumers to guide, empower, and motivate a change in behaviour, including adopting a healthier lifestyle and self-managing their conditions and medications. Care navigation provides a person with support and practical assistance to navigate the healthcare system until a person can navigate services by themselves. Care navigators are in certain community GP surgeries and can support consumers with a focus on translating complicated medical processes, systems, and language. Everything is done with the patient's goals in mind and is always in partnership with the patient. The clinician's monitoring of the patient's health and experience on an ongoing basis is key. PCBH functions on a 12-week enrolment. If the patient improves and is self-managed by the end of 12 weeks, they can be discharged. If further support is required, the care plan will be reviewed by all participants and the program continued. Managing multiple long-term health conditions can be overwhelming for people and their families. The support provided by PCBH will help individuals to understand and self-manage their conditions, enhance the relationship between the hospital, general practice and community setting, educate and connect individuals so they can be in control of their own health through self-management, and ultimately keep people healthier and out of hospital, at home, in the community.
And with a caveat that part of that talks about there being care navigators in some GP surgeries. That applies in country areas, not so much in the city areas. So we sit within the health service in the city areas. Okay, so one of the things that we also do as part of it is the 48-hour follow-up. The 48-hour follow-up patients are gathered from the patient flow portal, and we do a list every day of those that have been discharged from the hospital within the last 48 hours. We then look at that list and look at those who might benefit from having a follow-up phone call to make sure that they've had their discharge summary, that they've got their medications on discharge, that they know what their follow-up appointments are. We ring lots of clients and they've got no clue what their follow-up appointments are, but we can see that and source that for them. They don't have a discharge summary. They don't have a booked appointment with their GP, so we work with them around trying to get that booked in, sort of the foreseeable future. It's usually a more short-term intervention, but if we, sort of find with those clients that they need some more intensive support moving forward and some care coordination and health coaching, we log them into care coordination and put them on our program for 12 weeks. And it's at that point that you'll get a letter from us saying they're on service with us, this is what we're doing. If there's anything else that you need, so let us know. It's not a discharge destination. So now one of our other programs that is supported by the Primary Health Network is the Shire Weight Management Program. It is in partnership with the Integrated Care Unit and the Integrated Specialist Healthcare Education and Research Foundation. It's a non-government organisation part funded through CESLED to deliver health services using an innovative model of care. Uses holistic non-surgical approach to weight management, tailoring the weight program around a client's needs. The clients have access to treatment plan options, including health maintenance programs, dietitians, exercise physiologists, psychologists, health coaching and care coordination. These are the eligibility criteria. Basically, it's a concession pension card holder assessed as having financial hardship. So it's to support those people that would not normally be able to support, sort of intensive weight management programs. The client is currently not pregnant. They've not had any other previous surgical weight interventions, gastric banding, etc. Client consents to the transfer of information between providers and agrees to attend ISHIP appointments at Miranda and St George Private Hospital. So it's very much a localised approach at this point. So the long services picture. So in the current clinical environment across New South Wales, there's a large variability in the service space and type of services available for clients with long COVID symptoms. So these people are currently managed by one of the combination of following: self-management, GP, AMS management, other primary care and allied health providers, single specialist care for single system symptoms, so respiratory, multidisciplinary rehab, and dedicated long COVID clinics, which are closing at rate across, sort of all of the different areas. They were available, sort of within our area at St Vincent's and a few other places. They're now so oversubscribed that they're now no longer taking any more clients for the foreseeable future. So the Ministry of Health decided that the PCBH teams were well placed to look at managing those with the current models that we use. This was sort of the ACI's breakdown of why we should be doing it. They saw that the PCBH care provisions align with the needs of people requiring escalation of care. So the stage 2 escalation, so IC management by LHDs. The care coordinators working within the PCBH initiative across the LHDs are skilled clinicians, so we're a multidisciplinary team. And a lot of the work that we're doing with our long COVID clients is very much around the Plan Care for Better Health model, with a few added extras. We've worked quite closely with people like Martina and, sort of getting into health pathways, ways of doing business. So inclusion criteria, they're clients with a history of probable or confirmed SARS-CoV-2 infections within 3 months from the onset of COVID-19 and with symptoms and effects that last for at least, sort of 2 months and cannot be explained by anything else. To date, the referrals that are coming through are patients who have transited the whole of the medical system trying to figure out what their fatigue is from. And we're now working with them, and they always have had past history of COVID, at least one infection, more than one infection most times. Obviously, the exclusion criteria is similar to a lot of other areas of support. So palliative care pathway, acute mental health problems, drug and alcohol case management. If they're being managed with mental health case management, that impacts. So they're not really eligible underneath that, although we do have clients where we are working in partnership with some of the mental health teams to support them. So how does it work? So they're identified, the referral can come from the GP. We now have a new interactive or editable PDF referral form that you can refer for all of our service space, which we will distribute to anybody that's come tonight. We have that electronically, don't we? And that will be sent out tonight. And you can refer to any of our services using that form via email. So basically, when they come to us, if they're referred from a GP, Martina's referred us quite a few patients. They're enrolled on the patient flow portal underneath the COVID initiative. We do initial consents, we do local intake assessment, we do the whole range of assessment to make sure that they're suitable for service. We then do comprehensive documentation. We have pharmacists on service who does pharmacy review. We've got OTs, we've got nurses. We then take them right through for the 12 months. They do patient reported measures as well on the HOPE platform, and we monitor them over a minimum of a 12-week period. And then if they need further treatment after that, they can stay on service. So referrals can come through on our normal generic referral form. This is a bit of have we got time now to do this? No, that's okay. So that, we don't have time. So how to refer, you can refer through our normal intake email. And as I said, that's all been sent through electronically, so we will get that to you in coming days.
Thank you for having us to let me speak. So, we're going to healthcare, especially very appropriately, so basically, we just wanted to talk about the new, supporting care services at St George and Sutherland hospitals. A little bit of background, so this, projects have come out of funding, the enhanced funding for palliative care, and trying to sort of decide where the money should go to consultations, lots of clinicians. And we identified that basically where the funding is needed is in chronic non-malignant illnesses, and that there was really a gap in funding for those patients who are in the last sort of 12 to 24 months of life in terms of palliative care support that they're getting. And this led to new services called the Community Supported Care Services. It was initially part of the Prince of Wales in January last year, and then started at St George Hospital in April 2023, which is my service, and Sutherland Hospital just started, and that's the medical specialist. So what is it? It's provision of specialist palliative care, medical and multidisciplinary team review of patients in chronic life-limiting non-cancer illnesses, in patients who have symptom issues, mobility issues, and advanced care planning needs. And we do sort of, for patients estimated to be in the last 12 to 24 months of life, but not yet appropriate for the traditional community palliative care team referral, which is sort of, 3 to 6 months of life, as much as we can sort of predict. So we are telehealth and clinic based mainly, but we are offering home visits at St George. And just going through sort of the members of the multidisciplinary team, the palliative care specialist, CNC, who is full time, social work, occupational therapy, physiotherapy, speech path, dietitian, psychology, and pharmacy. That's only available at St George.
Thanks, India. So what kind of patients are we looking for? Patients are living in the St George or Sutherland areas. The diagnosis of a chronic non-malignant life-limiting illness, that's more for the St George service. The Sutherland service is funded slightly differently, so we can take malignant patients as well. And the chronic non-malignant life-limiting illnesses we're mainly seeing end-stage respiratory diseases like COPD and interstitial fibrosis, cardiac failure, liver failure, and neurodegenerative conditions other than MND, which is seen in the Calvary MND clinic. These patients, if they're having complex or worsening symptoms, they're not responding to kind of optimal management of their underlying condition. If they're experiencing function decline and the need for increased services or supports at home or equipment, if they're having issues with weight loss or swallowing issues, carer stress. Another flag may be multiple presentations or admissions to hospital in the last few months. And that surprise question to you, would you be surprised if your patient would die in the next 12 to 24 months? We're very happy to help with any advanced care planning needs you have, because we know that can take a bit of time, which we have the luxury of doing in our clinics. The patients that we won't see in these particular clinics are those that are actively dying or having a rapid deterioration thought to be in their last 3 months of life, requiring high frequency palliative care nursing and medical support in the community. Those patients would be the patients that we refer to the Calvary community palliative care team. Obviously, if people aren't happy about the word palliative, that's a problem coming to see us, but hopefully with your gentle guidance, they will come around. And particularly if they don't have any MDT needs, this particular clinic might not be the right fit for them. But we do have other palliative care clinics at both St George and Sutherland that we can certainly see those patients in. we're really keen to build relationships with our local GPs. So after they're seen in our MDT clinic, a few weeks later, we will plan to discuss them in an MDT case conference. So you will likely receive one of these letters if you refer a patient to us, inviting you to attend one of our case conferences virtually. And a note there that you can attract a Medicare if you invite them for that as well. We do appreciate and understand that your time is, very precious, and I have parents who are GPs, so I understand those time pressures. So it's certainly not an expectation, but more of an invitation if you'd like to discuss your particular patients that you see. For the Sutherland service, we're talking about the outpatient website. That's where you will find us. Down again, thanks. If you scroll down, you will see that we're there as supportive and palliative care. Click on the how to refer. It will have the referral form there. And if you click that, it will take you to the outpatient referral form for pretty much all the different clinics. So we're trying to keep it nice and streamlined so you don't have different pathways to follow. If you just fill that out and send it to the usual outpatient email address, we will get it and triage your patients and see them as soon as we can. We do have a care coordinator mobile, which is up there. It's also on the information sheet that's been available outside. Please do give us a call, even if you're wondering which clinic you think the patient might be appropriate for. We're very happy to have a chat about it. And also, if you have someone who you feel needs our service quite urgently, please give us a call. We do have some flexibility when we see these patients. And then again, the Calvary community palliative care team referrals go through Calvary.
I'll just briefly talk about the St George Clinic. May not be so relevant for you guys, since I think most of you are away from the Sutherland area, but we've been going since April 2023. It's a hospital clinic on a Tuesday at St George Hospital. And medical myself and many of the CMC were predominantly clinic-based and we do telehealth, but we have done intended at some occasion for those really sort of home, housebound patients without much family support to get them to appointments or work out in telehealth. And the allied health actually predominantly research has been found it sort of, more accessible to patients that way. And we do actually see GBM patients in the clinic as a sort of exception to the rule. It's non-pregnant. So just some data, very preliminary stuff. Since April last year, we've had a total of 150 referrals, and of those 65 were appropriate transfers, and we've been seeing sort of quite actively. But the other patients we've actually been able to sort of redirect and send on to more appropriate services for them, which is actually really important for all of our CNC, we found out over time. We've had, 60% having formal documentation of advanced care plans or ECDs, and that plus sort of ECD completed and uploaded into the hospital system, or there at home with them. But all the patients that have come to the clinic have had discussions, advanced care planning discussions included in clinical notes. 18 patients have died so far, and 15 of those died at home or at Calvary in the public care unit, and only 3 actually ended up dying in acute hospitals. So I think that's pretty good in terms of allowing people to or helping people to die in their place of choice, basically. And there's certainly been a lot of hospital admissions along the way. So just a little sort of case vignette very quickly if we've got time. Sure, let's see so, this is one of our patients that we saw very early on, 71-year-old lady with end-stage respiratory disease. I think she had pulmonary fibrosis. She had been seen in the breathlessness clinic at St George Hospital, a few times to optimise the non-pharmacological management of breathlessness. In the 6 months preceding being seen in our clinic, she'd had 3 UD presentations and hospital admissions. She was referred to us in July 2023, and we saw her through a combination of telehealth and home visits. Everyone in the team saw her because she had lots of symptom issues. We did advanced care planning, we did, goals of care, we looked at her medications, you know, we put in equipment and aged care services in place. She then, when she became unwell, she chose to come into Calgary, and we had sort of discussions about how she wanted her care to go and manage some of the symptoms. She made it back home for, I think, a month or so after that, and then when she was, she was getting straight to the palliative care unit, and she died, I think, within a day. So that was a really good outcome for this lady who very much wanted to stay out of, you know, out of the hospital system. And we were able to manage her symptoms, you know, as best we could over that time that she had left. And those are the details of the Cinderich service, but just come up to us afterwards if you want some flyers and things, and how to refer.